A 6-week-old comes into the emergency department with a fever. Take that infant to one London hospital and they get bloods, a lumbar puncture, antibiotics and an admission. Take that same child with the same history, same observations and same examination to another unit and they might get a urine dip and a period of observation. So, which department was right? This fortnight, we're going deep on variation in how we manage the febrile young infant. Then, we're going to look at a negative but instructive bronchiolitis oxygen trial. And in What's Caught My Eye, we've got electronic sepsis alerts, neonatal head injury on the postnatal ward, and whether having access to a bigger respiratory virus panel actually changes anything. I'm Ian Lewins, and welcome to Two Paeds in a Pod. Welcome to Two Paeds in a Pod, the paediatric medical education podcast about thinking clearly when it comes to child health. Each week we take a paper, a clinical dilemma or a tricky topic and work through what it actually means for your practice. So, whether you're in emergency care, general paediatrics, or you see children as part of a wider healthcare role, this is a place to step back, challenge assumptions and sharpen your thinking. Welcome to the show. A quick word before we start. We covered febrile infants in the last episode, looking at risk stratification in the 29 to 60 day group. I'm coming back to the topic deliberately because this is a different question and an important one. Last time we asked, how do we decide which febrile infant is high risk? This time, the question is, once we have national guidance telling us what to do we actually do it? And does it matter which hospital you attend? Those are not the same thing, and the second one is arguably more uncomfortable. The febrile infant under 90 days is one of the genuinely high-stakes presentations in our speciality. The great majority have self-limiting viral illnesses. A small but important minority have a serious bacterial infection, whether it be a urinary tract infection, bacteremia, meningitis, and the clinical signs early on can be unreliable. That tension is exactly why we have national guidance. NICE in the fever in the under fives, the NICE febrile infant guidance, and the work that's gone into risk stratification tools. The whole point of the guideline is to compress that uncertainty into something consistent. So the real test of a guideline is not whether it exists, it's whether care looks the same across different hospitals when it's applied. So, this study is a retrospective multicentre cohort study across 21 London hospitals, run through the London REACH network. REACH being Research, Evaluation and Audit for Child Health. They looked at infants aged 90 days or younger presenting with fever or with caregiver reported fever over a 1-year period from April 2021 to March 2022, just over 2,000 presentations. The first finding is the variation in investigation. Across sites, the proportion of infants who had blood tests ranged from 55 to 97%. Lumbar puncture ranged from 17 to 71%. Urinalysis from 43 to 85%. Antibiotics were started in anywhere from 35 to 90% of infants depending on the hospital, and admission ranged from 47% to 99%. As you can see from the numbers, these are not subtle differences. For the same broad clinical problem, your chance of getting a lumbar puncture varied roughly 4-fold, depending on which London hospital you attended. The second finding was adherence to national guidelines. Full adherence was achieved in just 21.9% of presentations, partial adherence in 24.4%, and non-adherence in 31.2%. And this is the one I want you to hold on to, over-adherence in 23.5%. That is investigation and intervention beyond what the guideline recommends. So roughly 1 in 5 infants was under-investigated relative to guidance, and roughly 1 in 4 was over-investigated. Adherence was better in the under 28-day group, which is reassuring. We are careful with the youngest, and better in those febrile at the point of assessment. A couple of caveats with this study. This is retrospective, so adherence is judged against documented care, and documentation is not the same as what happened in the clinician's head. It is London specific, a dense urban system with a particular case mix and tertiary access, so the absolute numbers will not transfer directly to, say, a district general hospital elsewhere in the UK. And the study period overlaps the later pandemic, which distorted both attendances and testing behaviour, particularly around COVID. So, what's the takeaway? We tend to worry about under-investigation, the missed serious bacterial infection. And that anxiety is legitimate and it drives a lot of our behaviour. But this study shows the variation runs hard in both directions. An over-investigation is almost as common as under-investigation. An unnecessary lumbar puncture, a septic screen, intravenous antibiotics, and a hospital admission in a well baby is not a neutral act. It carries procedural risk, antimicrobial exposure, family distress. It carries a cost and it occupies a bed. The deeper point is that a guideline only delivers consistency if it is usable at 3 a.m. by a tired registrar in a busy department. If full adherence sits at 1 in 5 across 21 hospitals, the problem is not individual clinicians being careless. It's that the guidance is hard to operationalise, particularly, and the authors make this point, for the infant who is afebrile by the time they are assessed, where the pathways are less clear. That afebrile on assessment group is where I would focus your departmental attention, because it's where the guidance gives you the least and the variation is widest. If you do one thing after this episode, look at your department's febrile infant pathway and ask honestly, is it a document or is it something a registrar can actually follow under pressure? And does it say anything useful about the baby whose fever has settled by triage? Because that is the baby this study suggests we manage least consistently. Our next paper covers that most popular of paediatric topics, bronchiolitis. And as we all know, bronchiolitis season is the workload that defines winter in a paediatric department. One of the small constant frustrations is oxygen titration. We put a baby on oxygen, the saturation swing, someone adjusts the flow, the saturation swing the other way, and a lot of nursing time goes into chasing a number. So the idea behind this trial is appealing. Let a closed-loop device do the titrating automatically, keeping the baby in a target saturation range without constant manual adjustment. The question is whether automating that actually helps the patient. This study by Croce et al., published in the Archives of Disease in Childhood this month, is a multicentre randomised control trial across 10 paediatric departments in France, running from 2018 to 2023. They enrolled 103 infants aged 1 to 12 months, hospitalised with acute bronchiolitis and needing oxygen, with saturations below 92%. Severe bronchiolitis was excluded. Infants were then randomised to automated closed-loop oxygen using the free O2 device or to conventional manual oxygen titration. The primary endpoint was length of hospital stay, measured in hours from emergency admission to discharge. On the primary endpoint, the trial was negative. Median stay was 71 hours in the automated group versus 69.6 hours in the manual group, so no meaningful difference. But the secondary findings are where it gets a bit more interesting. Time spent with the target oxygen saturation zone was 89% with the automated device versus 75% with manual titration, and median oxygen flow was substantially lower with automation, 0.1 litres per minute versus 0.3. There was no significant difference in rehospitalisation at 7 or 30 days or in non-invasive ventilation use. The honest limitation, which the authors state plainly, is recruitment. They enrolled 103 infants over 5 years against a backdrop that included the pandemic. This is an underpowered trial, and a negative primary endpoint in an underpowered trial tells you less than the negative endpoint in a fully recruited one. Absence of evidence here is not strong evidence of absence. So what? Well, the clinical bottom line is twofold. First, on current evidence, automated oxygen titration does not shorten length of stay in bronchiolitis. So this is not a technology to argue for on the grounds that it gets babies home faster. Second, and more useful, the secondary signals are coherent and point the same way. The device keeps infants in the target range more of the time and does so at lower oxygen flows. That is mechanistically plausible and internally consistent. There's a wider teaching point worth drawing out because, of course, our audience spans trainees and consultants. This is a clean example of why you read past the abstract's first line. Negative trial is not the same as nothing happened here. The primary endpoint may simply have been the wrong endpoint or the trial too small to detect the effect on it, while the physiological secondary endpoints tell a consistent story. The discipline is to ask what the trial was actually powered to find, and whether the question it asked was the question that matters. For bronchiolitis specifically, length of stay is driven by feeding and overall clinical trajectory far more than by the precision of oxygen delivery. So it may always have been an insensitive primary endpoint for this intervention. If you want to follow this further, it's worth reading alongside the bronchiolitis oxygen target literature and the Paeds work on permissive hypoxemia, which is a bigger conversation this trial sits inside. Next then, let's move on to which 3 papers have caught my eye this fortnight. The first is Do Electronic Sepsis Alerts Actually Save Children? By Driver et al. From the Journal of Paediatrics and Child Health this year. This is a systematic review and narrative synthesis of 12 studies of automated EMR-embedded sepsis alerts in children under 18. The headline finding is that alerts improve process measures, faster time to antibiotics in 4 of 6 studies and faster fluids in 2 of 5, without increasing hospital admissions or overall antibiotic use. A mortality benefit was demonstrated in only 1 study in a PICU population. So why does this matter? Well, as more NHS trusts switch on electronic sepsis triggers, this is an honest evidence position. Alerts reliably move the process metrics, but the hard outcome data, particularly mortality, is not yet there. The caveat, of course, is that the studies are heterogeneous and mostly observational, so the absence of a clear mortality signal is not the same as proof that alerts do not help. Next up, something most of us have never seen written down, and that's the neonatal head injury that happens on your postnatal ward, by Corsini et al. From Hospital Paediatrics. This is a retrospective cohort across 15 Italian maternity units of newborns who sustained a head injury from an in-hospital fall during routine postnatal stay, with the Pecan rule applied retrospectively. The headline finding was that 39 newborns, median injury 32 hours, most falls occurring at night during rooming in. A quarter had a clinically important traumatic brain injury, but none needed neurosurgery and none had sequelae. And almost 90% of low-risk babies were imaged anyway. Why does this matter? This is a low severity but high anxiety event that triggers extensive imaging and prolonged stay, and it sits right on the edge of where PCAN was never validated, the newborn. The caveat for this study is that, of course, 39 cases is small, and applying a rule designed for children under 2 retrospectively to neonates is exactly the kind of extrapolation we should be cautious about. And finally, a stewardship question for the winter. Does a bigger respiratory virus panel change anything? From Stephen et al. In Paediatric Emergency Care. This is a retrospective cohort of 2,346 children discharged from a paediatric ED with a viral respiratory illness, comparing a limited 3 pathogen panel against a comprehensive 22 pathogen panel. The headline finding? There was no difference in 7-day return visit rate between limited and comprehensive testing after adjustment, and no difference in intervention or disposition on return. So why does this matter? Well, for the well child being discharged with an obvious viral illness, the bigger panel did not change outcomes. A clear argument for testing less, not more. The caveat, as always, is that this is a single centre and retrospective study, and it speaks to the discharged outpatient, not the admitted or immunocompromised child, where broader testing may still earn its place. So, 3 things I'd take away from today's episode. Number 1. With febrile infants, our variation runs both ways. Over-investigation is almost as common as under-investigation, so look hard at your own pathway, especially for the baby who's afebrile by the time you see them. 2. The automated oxygen trial was negative on length of stay, but coherent on its secondary endpoints. A reminder to read past the first line of the abstract and ask what the trial was actually powered to find. And thirdly, electronic sepsis alerts reliably speed up antibiotics and fluids, but the mortality evidence is not yet there. Useful to know before your trust switches one on. All references for all the papers and DOIs are in the show notes. If this episode was useful, please like, subscribe and share, and I'll see you in a fortnight. Thanks for spending your time with us on 2 Paeds in a Pod. If this episode sharpened your thinking, make sure you're following or subscribed wherever you listen. Share it with your team, use it in your next teaching session, and let's keep the conversation going. If you value this kind of learning, please leave a rating or review. It genuinely helps more clinicians find the show. We'll see you next time.